Morning. Good morning. You're welcome to our today's lecture. Today, we take a look at action and uses of medicines. In Unit 2, we are still discussing the topic factors that do what? Factors that do what? They based on what? Effect of what? Drugs, okay? So we are discussing the environmental factors. We are discussing the environmental factors. In our last class, we stopped at the effect of diseases. The effect of diseases. So today we'll start from hyper susceptibility to drugs. Hyper susceptibility to drugs. You know, under normal circumstance, at normal dose, effect of drug is there's an expected effect of a drug. But we have these variations in individuals where you have one where that normal effect that should be associated with that dose will be more on a particular person than the other one. It's not as if maybe the person is maybe overdose or it's just normal dose, but you realize that the effect in person A will be more than in person what? B. So you see this maybe, for example, that drug like diazepam for what? Is an anti what? Is an anti what? Present, okay. For anxiety, maybe to take care of anxiety. You realize that in some patients, in some persons, there will be no, you know what hangover is? The alcoholics will know that one more. Hangover, maybe after taking alcohol in the night, in 2 hours in the morning, the effect will see what be there. Am I communicating? Now, in some persons, you realize that the nothing once they take the drug, it does what it should do. The person the next morning or the next day, the person is okay, going about his work, normal work activities. But in some persons, the effect will still be there. The person will start feeling, the effect associated with this. Maybe some people call it Ogwola sleeping pill because of the effect, this effect it has to make you what? Sleep. Am I communicating? Now you know that in some patients, the effect will be more even to the next day. Am I communicating? So this what we mean by hyper excess what? Susceptibility to a particular what? Drug. Hyper. Okay, so the action will be prolonged. The action will be prolonged in some patients. This does not happen to anti-anxiety alone. Even some opioids like morphine, even some opioids like what? Morphine. Under normal circumstance, maybe between 4 to 6 hours is effective, but with time, in some patients, not competing. So this is just as this happened as a result of what? Variation in what? Individual. This one is the abnormal dose, do not normal dose. Normal dose. You start seeing these differences in what? In what? Individuals. So that's what we mean by what? Hyper what? Susceptibility. Hyper what? Susceptibility. So some patients are hyper susceptible to the particular to what a particular what drug than what the other. Okay. Now hypersensitivity. Hypersensitivity, another factor which I want us to look at is what? Hyper what? Sensitivity. Hyper sensitivity. Good morning. Hyper sensitivity. I think I said one or two things about this in the genetic in the genetic factors. I mentioned it. I mentioned it. Okay. What is the typical symptoms you see? Of course, it has to do with allergy, right? Hope you know. Are you aware? Yes. It has to do with what? Allergy. So, and I want us to realize here that basically hypersensitivity is an abnormal what? Response. Am I communicating? Is an abnormal what? Response towards some drugs. Okay. Now, even in a dose that is below the what therapeutic dose, you can still do what experience it. I'm not communicating in some people. So now, what actually sometimes you start seeing things like even hematological disorders may do what ensue in some individuals. Hematological what disorders, blood. Is it here we made mention of dyscrasias? Is it here? Huh? Okay. I thought we made mention of it some time ago. Is here. Someone look it up. Someone look it up here. Okay, I think it's sad that she's not here. Okay, hematological issues may also do what? Ensue. Now, when we do as asthma, okay, I think that should be a second semester. You understand better what this allergic reaction is all about, because asthma is all about what? Allergic what? Reaction. It's all about what? Allergic reaction. Is that is usually what? Abnormal. That is usually what? Abnormal. So that's the most important thing you need to learn here. Of course, when we discussed, remember when we discussed the use of intradermal injection, we mentioned that we use it for what? For testing, right? Maybe if you want to administer a particular drug, you can give a test dose intradermally to see what happen locally. I'm not communicating before you can give the what injection. Are we together? Now, in that sense, now there are some drugs that usually, in fact, they are known for such issues. Things like penicillin. Penicillin generally, before you give penicillin as an injection, you should be careful. I'm not communicating. You should be very what careful. Forget this one. You take it orally, and in most patients you not experience anything. Well, once it's entering through parenteral means, which you what very what careful with them, because there's high chances of what allergic reaction. Am I computing high chances in most of the what patients? So of course, I wouldn't want to spend more time there. I explain things you should do. You should use you do testing, right? You usually test those. You should also get drug to take care of allergy standby, right? Remember all those things that you should also do what again? Take history of the patient to know whether the patient react to such maybe a drug that is related to this, because penicillin is a very big family. Penicillin is a very big family. A lot of drugs, a lot of subclasses, a lot of drugs are under what? Penicillin. Okay, so each of them has their own effects. By the time we go down to to cross tolerance and other things, you start seeing, don't worry, there's this general, there is this general statement that drugs that have heavy molecular weights, that drugs that have heavy molecular weight have this high tendency to show what? Hypersensitivity. Drugs that have very heavy molecular weight, there are high chances that they will do what? Cause what? Hyper what? Sensitivity. Please note that point. Most drugs that have high or heavy molecular or high, either heavy or have high molecular weight, there's great chances that they can cause what? Are you together? Are you together? Okay. So now I mean, see that in as much as here, there's the drug that have this on their own, but individually, people, these reactions, the A may show it, B may not do what? Show. In some situation, A may show, B may not do what? Show. There are some people that if you give them chloramphenicol, are you together? No, sorry. If you give them chlorpheniramine, they just sleep off. But me, if you like, give me two tablets, I won't feel anything, sir. Am I communicating? And there are some that if they take chloroquine, they will dance from morning till night. But if I take it, nothing. So if you have you seen this individual what differences? So it exists. It exists. All right. The next factor I want us to talk about is tolerance. We have discussed tolerance at length. So, but pointing it out again, there's something else. There's something new I want to add there in that tolerance. So that's why I want to just say one or two things about it again too. So it can usher us into what is called cross tolerance. Cross tolerance. So tolerance, of course, when you take, you see the effect, you enjoy the effect. Now, if you keep taking again, it to get to a point that amount you take to give you a particular effect may not work. You're able to achieve it again. You need to keep increasing the amount so as to get what the desired what effect. So the more you take, that what so the body is becoming resistant. But the body should respond, right? But the body is becoming resistant to that particular amount that should make it to react, to respond in a particular way. But because you need to achieve that particular what effect, you need to take more of what doses to be able to do what achieve what the effect. So this is seen mainly in alcoholics. They will take today they take, tomorrow they take. It will get to a time self if they just take two bottles, it looks as if they did not even take anything. Two of us, it looks as if they did not even take anything, unless the person intentionally decide to. But the body will be like, the body will not even feel anything at all. Am I communicating? The body will not do what? Feel anything at all. Even those that take hard drugs like cocaine, name them, the same thing. The more they take, the more they want to take more. Am I communicating? So, all right. So now, if you see those that are alcoholics, they do not respond to analgesics and what hypnotics. So if you want analgesics if you want the effect of an analgesic to be pronounced in their system, if they wanted to actually take care of headache, the normal dose you take will not be the same thing they will take. They want to take more, keep taking until they of course it most of the time tilt towards what toxic level. Most of the time it tilts towards what toxic level. Now we have discussed tolerance, so I wouldn't want to waste our time here again. I want to talk about cross tolerance. Cross tolerance. You may have two drugs. Are you aware that you may have two drugs that have the same structure and have the same effect. Sometimes you may also see two drugs that don't have the same structure, but they have the same effects. Am I communicating? Yes, it happens. They may not have the same structure, but they take care of the same. They have the same. They take care of the same. They can use for this to treat the same issue. Am I communicating? Now this will usher us in what is called what complete tolerance and incomplete cross tolerance and incomplete what cross what tolerance. They generally cross tolerance talks about if a patient is develop tolerance to a particular drug, it may likely develop tolerance to a drug that looks like that what drug. Am I communicating? That's what happened in cross. Remember when I talk about cross resistance here? Remember when we are talking about microbial resistance, I told you about cross resistance. Just because you have I have abused antibiotic for a long time, and the people here abuse antibiotic for a long time, and the I'll have we have strain of bacteria or whatever that is resistant to that what antibiotic. Of course, most of these bacteria can move from person to person. I hope you know. If you deposit, you come and do what? Collect, right? Now, if it enters another person's system, that strain that is resistant to a particular drug enters another person's system. There's that high tendency that when the person take that drug, the person the drug may not be able to take care of what the illness, because that resistance is there. I'm not communicating. Now, when we have this tolerance now, when somebody developed a tolerance to a particular drug, that you need to increase the dose for the person, for the effect to be felt, or for the treatment or whatever reason you are taking the drug to be taken care of. For you to do that, you need to increase the dose. Now, if such patient take another drug that looks like that one, either by structure or pharmacologically, the person will also be what tolerant to that particular what drug. That's what cross tolerance is talking about. This is drug A and this is drug B. Drug A and drug B, they may look alike by virtue of the fact that they have the same pharmacological effect. That alone will make me, if I take this B, I will also have tolerance to B, because I am tolerant to the one that looks like it, either pharmacologically or by chemical what structure. So that's what cross tolerance is talking about. So when you talk of complete cross tolerance, there you are talking about that particular. Let's assume that there are some drugs that they share the same, maybe they are in the same by structure, they are in the same class, they have the same structure. Maybe just a minor, they have the same nucleus, maybe just a minor substrate group, okay? Methyl group is not in this one, all this just peripheral, just substrate group. But they have a similar structure. If I develop tolerance to this, I also develop tolerance to the other one. So that's what is called what? Complete what? Tolerance. But in incomplete tolerance, they may not have the same chemical structure, provided that they have the same pharmacological what? Action. If they have the same pharmacological action, that type of, if they don't have the same chemical structure, but they have the same pharmacological what? Action, that type of cross resistance is what is called what? Incomplete cross resistance. The key point there is that when it comes to complete, they have the same structure. The two drugs have the same what? Structure, similar structure, but chemical structure. But when it comes to incomplete, they don't have the same chemical structure, but they have the same what? Pharmacological what? Actions. There are many examples like that. Like now, when it comes to complete, you see things like maybe if you have morphine, and the derivative of morphine maybe by virtue of changing one substituent group or the other one, you realize that if you are tolerant to morphine, you will tolerant to what? Example, betadine, good, because they have what? The similar chemical what? Structure. The same thing with diazepam and what? Flurazepam. Now, but let's assume there are some things like when it comes to barbiturates and general anesthetic, they don't have the same chemical structure, but they have the same pharmacological what? Action. You also develop what? But that one is what? Incomplete what? Cross what? Cross what? Tolerance. So I mentioned tolerance again because of this cross, or if not, we have discussed that. So I wouldn't waste our time on that again. So what do you understand by the term? Okay, those that have gone through this thing. Tachyphylaxis. 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 This also has to do with what? To do with what? Tolerance in a way. In a way. Okay. So here now, there are some drugs that if you keep administering them repeatedly, they will do what? They will do what? They will do what? Let me ask a question. From the look of things, a lot of you have gone through this. So share with me. What do you understand by understanding, not notes, not cost material? What do you understand by tachyphylaxis? Share with me. Uh-huh. Sudden what? Why? That's what I want to hear. Why? Eh? There's something I'm looking out for. What's the reason?
Happens in roads that I was in there. That is based on the indigenous receptors.
Uh-huh.
Let's say adrenaline and non-adrenaline.
Okay.
So once the indigenous receptor, in this case, no adrenaline,
It's receptor. Okay, sorry, continue.
finishes or is exhausted,
Okay.
the I think the system become tolerant that drug because of the exhaustion of that endogenous receptors. Also, that non-adrenaline realizes what that reliability effect is exhausted. So it's no longer.
Who else? The same thing with see. This whole thing has to do with what? Listen carefully. It has to do with what? Tolerance. But there's something. There's something happens. I think that's what he's trying to explain, and that's what he's trying to. There's just as he mentioned some endogenous what receptors. Now, if they don't, some drug that don't act directly, they will act on a particular store to release like now this arena now you mentioned when they stop, if the action is not as if it's acting directly, the store effect is in the store. When they are now released, they will now do what? Exert their what effect. Now when that store of this substance is exhausted, if you like, give maximum dose, keep giving. There's nothing else to release that will now exert the what pharmacological what effect. It's not as if that drug you are giving is acting directly. It just like it will go and burst something. That's a particular store. I'm just using maybe that's a particular store filled with some things. Just like maybe if you want to, for example, if you want to, there's a bag or something here. Let me use something that we can live easily with. There's water. There's a bag, and you are here, standing here, and there's a nylon filled with water hanging on top of your head, right? Now, I want water to touch you. Instead of carrying water to pour on you, I will target that bag first to burst the bag, then the water in the bag will now touch you. Now, if the water in the bag gets exhausted, if I like, let me fire from now till tomorrow. There's no water again to touch you. Am I communicating? The more if I like fire, I will not even feel anything. Yeah, keep firing, keep firing, keep firing. Am I communicating? So such drug, they don't act directly. They will act on the store to release mediators that will not go and endogenous substance that will not go and act. I'm not communicating. So if it's exhausted, not if you like, fire to fire 100, fire increase the dose to the maximum, nothing. That is the type of tolerance in that case we call this one what? Tacky what? Phylaxis. Am I communicating? Tacky what? Phylaxis. So that's what he's trying to do what? Explain. So repeated administration of a drug at short interval of time leads to rapidly developing tolerance. Okay, it occurs with indirectly acting what? Drugs, or repeated administration when you keep giving these drugs. Depletion of endogenous receptor do what? Endogenous receptor. Once that receptor is exhausted, forget it. Nothing else. There will no effect. So this is also known as what? Acute what? Tolerance. So tachyphylaxis is also known as what? Acute what? Tolerance. Know that point. Example now is ephedrine. This ephedrine, see what ephedrine does. Ephedrine acts by what? Releasing noradrenaline. Noradrenaline from where? Adrenergic what? Store. So adrenaline is stored. Noradrenaline is stored in the adrenergic store. Now the ephedrine, when you administer ephedrine, it will go to release the what? Adrenaline that will now act. The ephedrine is not the one acting directly. It's when you take it, it's when you administer it, it will go and release noradrenaline from where? Adrenergic store. Is that adrenaline that will do what? Act. Does it make sense? So when you keep administering, to get to a point, the store will be what? Exhausted. So if the store is exhausted, from logical action will not be restored, no matter how the dose you give. Am I communicating? So this is what is all about. This is what is all about. Okay, now let's look at the last group of factors. Interaction of drugs. Interaction of what? Drugs. Under this interaction of drugs, we look at synergism and what? Antagonism. We look at what? Synergism, antagonism. We look at synergism and what? Antagonism. Synergism and what? Antagonism. So let's start from synergism. What is all about? Is a situation whereby the effect is increased by doing what? Giving two words, combining two drugs. But this combination takes different forms. Am I communicating? When two drugs are combined, you say that the effect will be more. But the combination can take can be of different forms. We have the one we call potentiation, and we have the one we call summation or additive what effect. So under synergism, basically synergism is just using two drugs to achieve which is positive, is not negative. The basic thing is that synergism are unlike antagonism. They okay, synergism, okay, you are okay. If you are okay, you are with us, you are with me. That's what synergism. Okay, you are with me is what synergism. Okay, you are against me is what antagonism. Now, but we have two types under what synergism. How they now am I communicating? If you are with me, if I want to carry this table, and you also want to carry this table, are you not with me? Eh? Good. That is what synergism, that agreement. But under that agreement, two of us may come together and carry it easily, boom, right? But two of us may carry it, it looks as if I'm carrying it alone, two of us. But basically, two of us have the same intention, right? But how do we now carry it matter? So that's why you have potentiation, we have what? Additive effect. So now let's look at the potentiation and additive effect. Let's see what they are all about. Okay. Now, under potentiation, what happens is that the total effect, when you combine two of them together, the two drugs, the total effect they will produce will be more than the sum of their what? Effects. That's potentiation. The effect will be more than just okay. The effect of this is this. The effect of this is this. This on its own. This on its own. If you combine two of them, there's an effect. But potentiation will be more than that effect combined. Let's assume making it. Let me use numbers, even though. Let me just use number for example now. Just number for example now. A, the effect is 20 on its own, right? B, the effect is 30 on its own, right? If you combine the two of them, it's what? 50. Potentiation in potentiation is not 50. Potentiation is more than what? 50. Am I completing? The effect in potentiation is more than what? 50. That's what we are talking about here. In potentiation. Are we together? And very, very careful. In fact, in potentiation, if you are not careful, it can lead to what? It can lead to what? Am I completing? If you're not careful, so be careful about how you're combining. Watch the doses of the drug you're using. Am I complicating? Because it will be more than their what? Effect. So what happens in potentiation? Example of drugs, you see things like acetylcholine and physiostigmine. Acetylcholine and what? Physio what? Stigmine. Remember what I told you about esterase, right? Cholinesterase. Cholinesterase break down what? Cholines, right? Acetylcholine. Now, see how this potentiation is affected. Physiostigmine will now go to inhibit the action of what? Esterase that's supposed to do what? Break down what? So what if this is drug? Of course, it's drug now you take. Now, cholinesterase that is supposed to break down this thing, metabolize it, will now physiostigmine will now go to inhibit its action. So the action will what? Prolong. The effect may even be above normal. Am I completing? That's what? Potentiation. Another one is what? Levodopa used in treatment of what? Parkinsonism. Now, if you combine levodopa and the carbidopa, so what does levodopa do? What does it do? Huh? Is it your material now? Tell me, what does it do? It does what? Huh? It does what? Levodopa does what? I think there was one lecture I did on this thing, the effect of levodopa on no, 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 continue, I'm listening. Huh?
Leftover is about related, but carbidopa is the carboxylase. That's the
The
enzyme.
carboxylase.
Yeah.
The carboxylase is one that take care of what? The carboxylation of what? Levodopa, right? The carboxylase, the carboxylizes what? Levo what? But carbidopa does what? He beat the action of what? What? The carboxylase. Am I communicating? So it's your material now. Okay, all the hair from my mouth. I said that basically, these things happens mainly at the metabolism, at the metabolic level. Okay, so what happens? I said that on a normal, the carboxylate is an enzyme. The carboxylase is an enzyme. Okay, so it's enzyme, right? So we have in the metabolism of this, we have the carboxylation. This enzyme take care of what immediate what the carboxylation of what levodopa. Are we together? But carbidopa inhibits the action of what the carboxylase, so making it impossible for you to do what break down or decarbosylate what levodopa. So it's a potentiation of action. Okay, no. The action will be what is the effect will be what more than, because in fact the what was supposed to act and go, you keep acting. I'm not communicating. So if you do your pharmacokinetic well, better anyway, we are doing it at according to a level. You understand a lot of all this is I have been calling acetylation, decarbonylation. These things are different methods of biotransfer, drug or transformation, metabolism. Okay, now depending on the substrate group in that particular word, you just to remove the carboxylate, to remove the carboxyl group. Forget all long stories. Forget forget the beginning. The carboxyl group, the carbon, we just cut it off, right? Break it off, right? And if you start breaking up the something group, you are destroying the what? You are breaking it down. It's not true. Forget long grammar we are blowing here. Every profession has their own jargon, so that if you go to those in accounting, if they are saying their own, do like this. Those in law, they their own. Hey, what are they saying? The Kabuzile, what are they saying? Like all this. So don't be afraid. These are simple terms, okay? All right. So now the one we are familiar with, this first two contain the one we are familiar with the drug we take almost all the time, most of the time. Where we have here, who knows the what this drug? You are familiar with Septrin, right? Septrin, right? If you are familiar with Septrin, that this should be a banner, right? What does it contain? Sulfur what? Uh, he says, "What of mine? Which one?" Check what Septrin contain also. Uh-huh. Trimethoprim and what? So for what? Sulfamethoxazole. Sulfamethoxazole and what? And trimethoprim. It's a combination. It's a fixed dose combination. There's potentiation in that. Okay? In fact, sulfur, that sulfur methoxazole is a sulfonamide. It's an example of what? Sulfonamide. So sulfonamide is we have drugs under it. We also have your sulfadoxine, fancy that, or your amala is sulfadoxine what? Pyrimethamine, right? Sulfadoxine is also a what? Sulfonamide. Sulfamethoxazole is also a what? Sulfonamide. But in septrin or cotrimazole, the calculus septrin is depending on basically what? Cotrimazole, where you have sulfamethoxazole and trimethoprim. Now, this sulfonamide now is effective against some microorganisms, but trimethoprim is effective in wide range of what micro what organisms, even plasmodium. Even plasmodium. What does plasmodium cause? Even plasmodium. Trimethoprim is also effective as well. In what? In fact, there are some antibiotics that they put trimethoprim there because it has been studied and people that this. You can check it up. You can check trimethoprim does trimethoprim has effect on plasmodium. You can check up and see what is there and get back to us now. So basically, in potentiation, what I want you to take home is that the effect is always above the normal therapeutic what? Effect. Okay? That's basically what happens in potentiation. The effect is always above the normal what? Therapeutic what? Effect. So you should be careful. Did you see anything? Trimethoprim. Even not only plasmodium, even bacteria, both bacteria, plasmodium. So it has a wider range of what microorganisms. So if you combine them, they work synergistically, but it's a potentiation. Are we together? Now, let's look at the other part of what synergism. We have the one we call summation or additive what effect. So what happened here? What happened here? Look up. In potentiation, if you combine them, the effect will be more than their individual effect, right? But in additive effect or summation, if you fuse them together, the effect will be equal to the sum of their individual what effect. Let's assume this one is act on its own. It's act on its own. The effect this one on its own. The effect this one on its own. In potentiation, in summation, the effect when combined will be the same thing with the sum of their what effect. That's what happens in what potentiation or additive what effect. Please let me drink H2O so I can speak under the influence of H2O. All right, is it clear? Just summation of their what effect. It will be the same thing with the combined effect. Okay. So here now, the total pharmacological action of two drugs will be equal to the sum of their individual effect on simultaneous. Listen carefully, not when you give, you wait and give. No, I mean simultaneous at the same time. Okay, that's why you see them to avoid most of these drugs that you want to. Listen carefully. Most of these drugs intended for synergism, most of them come as fixed dose combination. Have I mentioned fixed dose combination in this class? Have I mentioned in your first year? Did I mention that fixed dose combination? Most of these drugs you want to target for synergism, always most of them come as what? Fixed dose combination, not as kit. Most time fixed dose combination, especially those that we have for summation effect. Those for summation effect, for summation, come as fixed dose combination because it must be simultaneously. Am I communicating? Sulfur, methotrexate, and trimethoprim. The two drugs are the two active ingredients are in one tablet. So that as you take the tablet, you take two of them. The same thing with artemether lumefantrine. The two of them are in one tablet. It's not two different tablets. So if it is two different tablets, it becomes a kit. But if it is a one tablet or inside one capsule, is a what? Is a fixed dose what? Combination. FDC. Fixed dose combination. FDC. Then kits. Who has seen ulcer kit before? Ulcer kit. Which company has it again? Ulcer kit. Ulcer kit. If you open it now, you see that the drugs are on their own. They are not combined in one. Amoxicillin is there or whatever. The antibiotic is on its own. The metronidazole or tinidazole, depending on the one they are using, will be on its own. Then omeprazole or whatever what PPI they are using will be on its own. They are not in one capsule. That one is kit. That's where that name came from. Ulcer kit is a kit. Ulcer was is a kit. It's not a fixed dose what combination. Okay, so let's look at here. Here we'll say things like aspirin and paracetamol. Aspirin and paracetamol. This one is what? Summation. Because the effect you will see will be normal therapeutic what effect. Aspirin and what? Paracetamol for analgesia. For what? Analgesia or as analgesic and antipyretic, as case may be. Open difference between analgesic and antipyretics. What difference between analgesic and antipyretic? Open. Paracetamol is more of antipyretic and anti-inflammatory. It's more of antipyretic. But aspirin is more of what? More of what? Analgesic, right? To compare with what paracetamol. Paracetamol is more of antipyretic. So if two of them are there, they can achieve this purpose together. I'm not complicating. So it's a good combination. Then as for bronchodilator, you can combination of ephedrine and what? Theophylline is also there. Nitrous oxide and ether as general what? And anesthetic is also there. In fact, you see this mainly more in even antihypertensives. You see combinations antihypertensives. Sometimes you see, if you see this one, maybe lisinopril, you see it with hydrochlorothiazide. You see sometimes you see calcium channel blockers, amlodipine. You see a lot of this combination exists. Am I communicating? So these things are there for what? To achieve what? Synergism. To achieve what? Synergism. I hope synergism is clear. Now let's look at antagonism. So as you unlike synergism, which is okay, are we together? Okay, we are together. You are not against us. Let's move. In antagonism, they are not together, right? They are not together. I feel as if it's where's the evidence? Bring it. Have you? You pay to do one time.
That's two.
Okay, you went and paid it exactly. divided it into two. You couldn't add extra, just like that. I think.
Yeah, no, I do extra math.
All right, let's continue. So, so today's antagonism. Sorry. So antagonism, basically, we have two. We have chemical and pharmacological. We have chemical antagonism and what? Pharmacological. So under pharmacological, are we together? Huh? I don't think we are together. Sorry. What did I say? Chemical, pharmacological, and physiological. Sorry. Chemical what? Pharmacological and what? Physio. Huh? Is that what? How can physiological be under pharmacological? How? Even use your common sense, how will it be under it? Even common sense, you go. There are some things you see, say common sense will tell you. Someone can type in the type error can exist, but common sense alone will tell you how physiological or not pharmacological. How? Check in here now. Check it now. Eh? Is what? So chemical is there, pharmacological is there, and what? Under pharmacological we have competitive and non-competitive. Is it clear now? Please, let's note that, please. Even you said that there are some things you write after writing, even textbook self, international textbooks. If we use it, you see it there, you see typo errors. Nobody is perfect. I'm not communicating, but there are some things you see. You can on your own think about it. Does it make sense? So, all right, let's start with what chemical what antagonism. So, what does it mean? What happens here? From the name, chemical reaction. Simple. When this drug antagonizes the other one by just a chemical reaction, by reacting with it. A typical example is what? A typical example is what? Good. Neutralization reaction. This antacid you take for heartburns, or ulcer patient heartburns, there is already a lot of gastric juice. Acid, the hydrochloric acid there is much. Then, when you take this antacid, and most of them are alkaline. They are alkalines. If you take it, they will react with the acid there in the stomach and neutralize it to reduce the acid level. True of us. So it's a chemical what? Antagonism. It's a chemical what? Antagonism. Apart from neutralization reaction, we also have chelation. Chelation is an example of chemical antagonism. Neutralization, as you see in what? Antacid, right? Neutralization. We also have what? Chelation. Chelation. I think I mentioned forming chelation here, where you mop up poisons, right? In the system, mop up poison, form complexes with poison to take them away. Form complexes, complex salt with complexes with this poison and take them away. We call it what? Chelation. You see that in where you have what? Heavy metal poisoning in the system. Heavy metal what? Poisoning. So you use chelating agents to do what? More take them away. Are we together? Example of such, we have your what? Diazepam. Diazepam is a what? Chelating what? Agent. Are we together? Okay, so this is what chemical antagonism is what? All about. It's at the surface level. It's at the what? Surface level. Just chemical reaction. Take it up. Okay. Even in iron, remember what I told you that iron, if iron is too much in the system, it's a problem. Hope you remember. So in iron poisoning, you use deposamine. Deposamine is used to do what? Remove the what? Poison. Am I communicating? By chelation, it will bind with the what? With the what? Sulfhydryl what? Groups to form insoluble what? Complexes. So they can easily be what? Detoxify. So this is also an example of what? Is an example of what? Chemical what? Antagonism. Now let's look at pharmacological now. Pharmacological what? Antagonism. Pharmacological what? Antagonism. So what happens in the pharmacological antagonism? Of course, remember when you did your what? Agonist and what? Antagonist. You have done that in your first year, right? Receptors, agonist, antagonist, fighting for what? Agonists and antagonists are fighting for what? Receptor. Am I completing? Good. That's their first year work. So example of pharmacological, we have what? Competitive or reversible antagonism and non-competitive what? Antagonism. So let's start with competitive antagonism. What happens in competitive antagonism is this. Here, basically, the antagonist, the agonist, and the antagonist, they compete for what? The receptor. Okay? They compete for the same receptor. They compete for what? The same receptor. So, if the antagonist wins, the effect of the agonist will now be fair. Three of us, because you need to bind to elicit its what? Effect. So most of the times now, the agonist, for it to fit, for it to even get morale, for you know that you know that on a normal, the agonist and the receptor, they form a lock and key. If the receptor is like this, for example now, if this is the receptor in the system, okay, the agonist must have something like this, a shape like this, so it can fit in. Okay. If this is the receptor, the agonist must have shape that looks like this receptor, so it can fit in. If it doesn't have this, if it has something like this, it cannot fit in. It cannot work. Am I communicating? So the agonist must have a shape that looks like what? That will be complementary to that of the what? The site to bind, so that it can bind and form a lock and key. Just like if you have your padlock and your key, if this key can only enter and open a padlock that have the same, that is complementary to this. Am I correct? So this is how receptor and agonist work. Now, for an antagonist to compete with an agonist, that means antagonists will have the similar structure. It's not true. If the structure is not similar, it cannot compete with it. True of us. Am I competing? So now, so this is basically what happens. I don't want to go into curve, left hand, right hand, all those things. I'll take you far, but just understand what happened at this level, okay? About the issue of lock and key. Okay. So basically, and basically, I think I have mentioned it that antagonists have chemical resemblance with the what? Agonist. Before you can even think of competing. Okay. Actually, in this type of competition, you can actually overcome the antagonist by increasing the what? The concentration of the what? Agonist. You can achieve that, okay? Agonist shift the dose response curve. What you call dose response curve. Dose and response. You shift the dose response curve to the what? To the what? Right. I mean, antagonist shift the curve to the what? Right. Now you see things like acetylcholine and what? Atropine. The antagonism between acetylcholine and what? Atropine on muscarinic receptor. We call it what? Muscarinic what? Receptor. Acetylcholine on the normal bind to the muscarinic what? Muscarinic receptor to achieve its purpose. On a normal, acetylcholine bind to what? Muscarinic receptor to achieve its purpose. But atropine compete with it for that the same what? Muscarinic what? Muscarinic what? Receptor. It's a typical example of what? Competitive what? Or reversible what? Antagonism. But listen carefully. When it comes to competitive or reversible, the structure or integrity of the receptor is maintained. It doesn't change. The antagonism is just competing with the what? Agonist. But the non-competitive integrity of the receptor will be changed. Am I communicating? A lot will be changed in what? In fact, it will even inactivate the receptor to the extent that agonist won't even see where to even. Am I so? In that case, this one is not reversible. Are we together? This one, there's no. Remember that in competitive one, you can actually overcome the antagonist by increasing the dose of the what? Agonist. But when it comes to non-competitive, that one you can, if you like, increase the dose of the agonist. Nothing will happen because the agonist won't even see where to bind. Just like two of us on a normal, I am owner of this phone. I know how to go about this phone, right? Now, because you are competing with me for this phone, you want to snatch it from me. You fight. You grab the phone because the phone is still okay. I can still do what? Retrieve it, or I can overpower you and correct it. But if you target the phone and destroy the phone, both along, nothing else to even fight for. Two of us. That's what happened in what? In what? Non-competitive. So they're going to even see anything to do, not know where to bind again. Because one, the structure, it may even transform a lot of things that you can't even see. You may even change the configuration, you can't even bind. Am I communicating? So that's what happened in what? Non-competitive what? So here, the antagonist inactivates the what? Receptor in such a way that the effective complex with the agonist cannot be formed, irrespective of the concentration of the what? Agonist. So that's what happened in what? Non-competitive. So this one is irreversible. Is it reversible? Is it? Do you think it is reversible? So how does he achieve this? The antagonists might combine at the same site in such a way that even higher concentration of the agonist cannot displace it. He may go there, that it can't even do anything. Do without here, it can't even do anything. The antagonist might even combine at a different site of the receptor in such a way that the agonist is unable to initiate response. He may go and attach to different sites that will cause some transformation that this agonist cannot even be would not even be able to do. Of course, when you buy at a different site on the same receptor, if effect will be felt, the receptor will be busy battling with the effect of the what is bound to it, right? That the agonist can't even see where to even do what space to do what settle. Now, I think I mentioned the last one I want to call now. That the antagonist may even induce a certain change in the what receptor configuration. It may reconfigure the whole thing. Get another, it may induce a change in the what receptor entirely. So the antagonist might even induce a certain change in the receptor, so that the reactivity of the receptor site where the agonist should interact is abolished. It may change this thing now. This thing may change to something else that this thing cannot even fit in again. Am I correct? So this one is brutal. Is what? Brutal. So what happened to this unlike in competitive whereby the antagonists may have the same, this one, the antagonists have no business with this structure. It came to destroy. It came to steal, destroy. He did not go for peace. He came to destroy, steal, and destroy, not for peace. Not for peace. Just like somebody will say, "If I cannot have you, no one can have you." You know that line now. You know that line. You should know that line. If I cannot, nobody can do what? You destroy everything. That's what happens in what? Not competitive. When we can so. So they have no chemical what resemblance. It just came to destroy. Simple. Duration of action in competitive is short, but this one is what? Long. Please know the differences. The difference between two of them is there in the material. Know the difference between the what? The two what antagonism. Please, you can select up to 10 differences from this material. Please study well. That there are points here. No difference between the two of them. Very important. Very important. I wouldn't talk much on that. Note the direction of the curve, okay, and the E marks, all those things. Now, example is this: phenoxybenzamine and adrenaline. The composition between two of them at alpha adrenergic what receptor. The other one is what? Example, acetylcholine is, it can also serve as an example, as a what? Difference, hope you know. Acetylcholine and atropine at most cardiac. Okay. Okay. Physiological what? Antagonism. So what is it? Is it all about? I'm listening. Tell me. So what happens? This one is doing his normal work. He's not here to fight anybody. He's not here to fight. He's just doing his own normal business. But his normal business is affecting this one normal business. Unintentional antagonism. Am I communicating? Unintentional, and even though we can still manipulate it because we know that you can use it, but unintentional, it's not as if they are fighting for anything. You know that the effect of this one is affecting what? Just as you were here reading, somebody is here, somebody is there discussing unintentionally. The person what the person is doing is affecting you. Unintentional. Am I communicating? So now what basically what happened is what? Physiological what? Antagonism. So here now the interaction of the drugs, all of them are both, no, two of them are agonists doing the normal work. So both of them are what? Agonists, and they act differently at different receptor sites. But their actions are antagonistic to each other. Okay. Yeah. antagonize the action of each other because they produce opposite actions. This action is opposed to the action, so they are antagonize what? Each other. Example now is adrenaline and what? Histamine. Histamine. Basically, adrenaline is a bronchodilation. It dilates the what bronchi, right? Basically, that's what it does. But histamine is what? A broncho what? Constriction. So in anaphylaxis, that's why I said that you can employ such in anaphylaxis now. This one adrenaline can now serve as a life saving. You know that histamine is a mediator. Histamine in allergy. Histamine is released. I hope you know. Are you aware? That's why antihistamines are used in allergy. Antihistamines are used in what? Allergy. Example: if you take chloroquine and they start itching you, what do you take? What do you take? Give me an example of the drug you can take. Piriton. Piriton is chlorpheniramine. It's an antihistamine. I said that histamine is implicated, is a culprit when it comes to what? Allergic reaction. It's released, it's a mediator. Release is one of the mediators released in allergy that mediate allergy, a allergic reaction. That's why I gave you an example of if you take chloroquine, it will start itching you, right? But if you take piriton, it will do what? Stop it. Piriton is an antihistamine. Is a what? Anti what? Histamine. Now, anaphylaxis is an allergic, is a serious allergic reaction. I hope you know. Now, when you use adrenaline, which is a bronchodilator, in that situation, it will become a life saving. It's life saving in that situation because anaphylaxis is what? Allergic. So it will act in action. We negate the action of what? Histamine. For example, now, am I communicating? Yes. So this type of thing you can employ this for treatments. Just as you can see here in anaphylaxis, you give what? Adrenaline. Am I communicating? Because the histamine is doing its work. I'm not fault here. It's adrenaline. It's doing its work. But you also know that there's another one that you can use that will have its own function. That will now be opposite to the action of what? To cancel everything. You now give what? Adrenaline, for example. Now, am I communicating? So this example of what? Physiological what? Antagonism. It's an example of what? Physiological what? Antagonism. So adrenaline and histamine, physiological what? Antagonism. Note these examples we've been given. This is pharmacology. This is action of medicine. All these examples, those drugs we've got up to 15 drugs today. Note where they belong to. Note these examples. Very important. Okay. So basically, what is the clinically? What is the significance of drug antagonism? Basically, what is the clinical significance? You can use your knowledge of antagonism to take care of what? To stop what? Adverse effects. Are you aware? You see what happened here now? And you see now, you can employ. Also, what happened in what? Using piriton, which is what? Chlorpheniramine against the itchy what? Chloroquine. Is the knowledge of what? Antagonism. Am I communicating that used there? Is antihistamine is released, is in allergy. Antihistamine is now used. You have employed your knowledge of what? Physiological what? Antagonism between histamine and what? And the chlorpheniramine. Am I communicating? Good. So another example is what? Ephedrine and what? Phenobarbital is also another example. So it's used to correct adverse what? Effect of a drug. Example, ephedrine and what? Phenobarbital. There are many of them. Chloroquine and what? Chlorpheniramine. Piriton is just a brand name of what? Chlorpheniramine. Piriton is a brand name of what? This is the generic name. Piriton is just the brand name. Okay. You can also use it to treat drug poisoning. You can use it to treat what? Drug poisoning. Remember what happens in chelation? Iron poisoning, right? It's a chemical antagonism. Hope you know. It will form a complex, right? Iron poisoning. Lead, heavy metal poisoning is also there. It's also a what? It's a chemical antagonism. So you can use to treat what? Drug what? Poisoning. So it's used to treat what? Drug poisoning. Example here is we have morphine. Treatment of morphine poisoning with what? Naloxone. Antidotes. Is chemical antagonism. It's knowledge of chemical antagonism that's employed in antidotes. We know that one now. It's knowledge of antagonism that's employed. It can be chemical, but most times most of the time it's chemical. But once it leaves the tummy and move into the system, it may go beyond chemical. It may start extending pharmacological or physiological. Am I communicating? Now, so you can use drug to treatment of what? Drug poisoning. Of course, now none of it can use to help you to have a guide you in selecting of drug for what? Optimum what? Activity. Hope you know. So you have to avoid drug combination. You see careful. If you know, apart from your knowledge of synergism, where you can combine drugs and have a better effect, none of antagonism here will help you to actually avoid some combinations that will reduce the efficacy of what? Some drugs. If you know that this drug antagonizes a drug, and you want to, there's what is called polypharmacy. There is what is called polypharmacy. Polypharmacy is where a patient is given many drugs at the same time. Maybe the person has ulcer. The person has diabetes. The person is hypertensive. The person has malaria. The person has typhoid. The same person. Hope you know it can happen. Typhoid. Diabetes and hypertension are they on their own? No? The person may even be HIV positive. He's taking that one. And malaria will not come. Ulcer is there. The person may even have the diarrhea. Drug will be here. We call that one poly what? Pharmacy. A lot of drugs given to one what? Patient. In that case now, your knowledge of antagonism will help you. As a pharmacist now, the doctor has prescribed, but you may look at this drug and check the one whose interaction may be antagonistic and know how to tell the patient to use it. Use this one so time. Use that so time. Yeah, the doctor is not the one to tell the patient. The doctor has diagnosed the patient, written what the patient should take. It's you in pharmacy that will see the patient and tell the patient how and when to take each of the drugs to be able to achieve the purpose for which the doctor prescribed the drug. That's why you should be knowledgeable about drug. You should be very good at when it comes to drug. It's not just about passing exams. It's not about what? Passing what? Exam. It's about being grounded. And if you are grounded, if you know what you are doing, even doctors will respect you because they know that they can count on you. They can come to you to make inquiry about drug. You become a drug informant. Yeah, everything about drug is you that they will come to because they know that you have something to offer. If it's not in your brain, you know where to get it. You know there are two ways of knowledge. One is having it where in your brain and knowing where to get it within few seconds. You will be in a place within few seconds you are getting the answer immediately. So having it in your mind, in your mind, and knowing where to get it as fast as possible. It's not somebody that knows something that knows where he can get it. If you're not grounded, you won't know where to get it from. Am I communicating? So, and this is the time to do that. This is the time to do what? To do that. So, you know the combination that you should avoid. Just like using penicillin and what tetracycline. You avoid that. You avoid something. Using ciprofloxacin and the iron containing what? Medicine. You run away from that. This whole thing will affect the what? There's antagonism there. Am I communicating? This fan here, these chairs, this beautiful board, this duster will be a witness that on this day we concluded the factors modifying dose and effect of what? Drugs. But I got a question. So our next topic is our next topic is classification of drugs by what? Actions. Okay? Our next topic will be what? Have I stayed up to 2 hours? No. So our next